Good afternoon, everybody. I'm just realizing and want to warn the other speakers, when you stand here, you can see nobody. So a vast throng of people comfortably seated in these luxurious chairs in this eerily blue room are now invisible. I should tell you, so you'll know that this is a good place, that extensive behavioral studies have demonstrated beyond any doubt that blue is the color that most prompts innovation. I mean, this is science. So I'm glad you're in this place and ready to learn and hopefully innovate. I'm Don Goldmann. I'm from the Institute for Healthcare Improvement, and my role today is simply to introduce the session and moderate discussion at the end. And we're hoping that when this very distinguished international panel of folks are done talking, you'll have saved your questions and thoughts for that time, and then we'll probably, at least I hope, we'll have at least 15, maybe 20 minutes to discuss. The rationale for today's discussion really is the observation, I should say the repeated observation, that often we have tremendous will, some great ideas, and we even think we know how to execute on a problem to demonstrate that we can really make progress and improvement. And then we find at the end of the day that the results are disappointing. And part of this, I think you'll hear today, may have to do with our general inability or lack of foresight to evaluate in real time what's going on the ground, what's happening in the context, what's going on with the theory and the changes we started with, so that we can help those trying to execute adapt what they're doing to the realities of the situation as it progresses. Currently, the model very often is, let's do our project, an external evaluator at the end of the day will tell us whether we succeeded or failed, and very often we will have failed and not know why, or succeeded and not know why. So that, I think, if the panelists will nod their head, is the gist. Thank you for nodding your head. It is the gist of today's presentation, and I'll just get off the podium and let each speaker tell you who they are and get on with the proceedings. Thanks.
So good afternoon and welcome to this session. I think the fact that so many of you are here just shows what a growing importance this topic is to the forum. The title of the session is What Can We Learn from Evaluation of Improvement Initiatives? And our subtitle is Developing an Integrated Perspective. And let me explain why. In the planning conversations that I had with Gareth and Mary about this session, we began to reflect on our experiences over a number of years of being in the field. The experience of a leading improvement organisation, the IHI, a major funder, the Health Foundation, and a senior evaluator, Leicester University. And as we began to reflect on our experiences, we found there were so many points of connection between our different perspectives. And I think this is really important because so often the relationship between quality improvement scholars and quality improvement practitioners has been an uneasy relationship, so much so that many think of that as an empty space in the scholarship. But I think it's a very full space and growing space. So each of us will share our perspectives on the journeys that we have taken in our organisations in recent years. Now, the abstract had promised you a synthesis of findings from major improvement initiatives. We're not going to present that, but fear all is not lost, because we have this week, the Health Foundation launched a report we commissioned from Mary Dixon-Woods a review of the Health Foundation's evaluation interventions, and this report is called Overcoming Challenges to Improving Quality. You can get it from our stand, you can download it, and it has some really useful synthesis and points of observation about some of the challenges and opportunities in the field. So I'm going to offer you a perspective based on two evaluations that I've commissioned. The first was the Safer Patients Initiative, which we commissioned back in 2003, and the second is the second phase of our Safer Clinical Systems programme, which is going live just now in 2012. And I'm going to offer some fairly kind of candid learning, really, about what went wrong and what we've learned along the way. So the SPI programme, as we called it, had two aims. First, to test ways to improve patient safety on an organisation-wide basis. But importantly, it aimed to achieve significant reductions in adverse events, mortality, and it had the aspiration to transform in just 2 years the patient safety culture of the organisations that would take part. This programme ran in 2 phases. It used a change package with 4 areas of care and I think around 40 discrete programmes of work. And it used a quality improvement collaborative methodology, including 15 to 20 staff from each of the organisations involved. Because our starting point was this idea that this programme had the power to transform a whole system of care, we commissioned an independent evaluation that would test that question, would say, could we see effects of the intervention at a system-wide level? So we commissioned a controlled observational study, a multi-method study, including before and after patient records review that also looked at adverse events and mortality, staff surveys and interviews, and repeat ethnographic study. So the reports landed at the Health Foundation, and some of the reading was quite difficult for us at first because we really believed that this programme had the potential to transform whole systems of care. And the evaluation found the following. First, that certainly among the senior stakeholders involved, there were high levels of knowledge and enthusiasm for this programme. But the first problem was this, that enthusiasm and knowledge had not sufficiently penetrated to the medical ward level. Staff on those wards, in general terms, were less familiar with and less practising of the ideas behind the programme. And as compared with the control sites, the evaluators found few differences in quality standards, and overall, little evidence of what one might call an additive SPI effect. This was disheartening, not least of all for the hospitals involved in the programme, who had been collecting their data for improvement throughout this period, and many of them had shown what seemed to be very impressive results. How could you square that with the results of the independent evaluation? We realised that the evaluation, in fact, didn't challenge the positive results of those hospitals in their pilot populations, but it very much challenged this wider aspiration that the intervention might lead to an organisation-wide effect. We spent much time at the Health Foundation wrestling with the results of the evaluation report and trying to understand why this aspiration hadn't become a reality. And over time, we came to realise a number of important observations which I want to share with you now. The first is this aspiration to create system-wide change did not translate into the programme design or the programme delivery. In fact, the intervention was highly localised. We hadn't even built into the programme an explicit strategy to spread, so of course you wouldn't see spread throughout an organisation. With only 15 to 20 staff engaged in the programme, in hospitals often employing 4,000 to 6,000 staff, through this quarterly collaborative process and online support from the faculty of experts, there wasn't a dosage of intervention that would truly catalyse a system-wide effect. And critically, we did not distinguish between 2 things, motivational goals and evaluative goals. We know that motivational stretch goals are important in helping organisations reach new levels of reliability in care. But we have to be clear that those are often stretch goals. They're not evaluative goals, because often we won't achieve those aspirations, and if our evaluations are designed to look for them, they will conclude with null results. We found that the organisations involved had major problems in creating the right data systems. This really slowed and stymied their progress along the way. Maybe we had naive assumptions at the start. We realised that actually improving and embedding patient safety is a massive challenge, and it's a long-term challenge that you cannot see achieved in a short-term project. And we conclude that actually this was in some ways a fairly emergent intervention. We thought we were setting out with a well-defined a priori intervention. It wasn't. It was quite emergent. In other words, we were probably more in innovation mode than demonstration mode. And that has big implications for the kind of evaluation design that are realistic. So, the evaluation was bound to conclude with the results that it concluded. We also felt, though, that the evaluation itself was too detached from the reality of the programme, from understanding what the objectives of the programme were actually on the ground, to ensure that the evaluation design maintained a strong alignment with the programme design. And fundamentally, we recognised this, that with hindsight, We should have done much, much more together, the Health Foundation, the technical provider, the sites themselves, and the evaluator, to develop and then critically examine the underlying theory of change. What are we trying to do here? What are the delivery mechanisms? What's the dosage of intervention? What's the likely tempo of intervention? When might we see changes? Without a shared explicit mental model of those things, you cannot have an evaluation design well aligned to your program design. This may sound obvious now, but hindsight's a wonderful thing. And in fact, the evaluators in their report to the Health Foundation concluded that if we had done this, in that case, a more focused and less ambitious intervention and somewhat narrower evaluation might have ensued. This, for me, raises a fundamentally important question about the relationship between improvement scholars and practitioners. We've got to, I think, tear down some of the barriers that exist, the classic one being the data for judgment versus data for improvement distinction, and really work together to understand each other's worlds and engage with them to create program design and evaluation designs that match up well. So where are we now in 2012? So I'll share with you just very briefly the second phase of a program we're just launching called Safer Clinical Systems in its second phase. So this program aims to improve patient safety by improving system reliability. And 8 organisations will work on us to improve their systems in 2 areas, prescribing and handover. And the approach we use has 4 key aspects to it: pathway definition, system diagnosis, option appraisal, and system improvement cycles. We wanted to commission an independent evaluation of this program that would offer an independent, critical perspective on this 4-stage approach. We also wanted to determine the extent to which that approach helps to make those systems safer. And really important, let's try and explicate here the mechanisms of change and the important contextual influences that have an important role to play. So what's different this time? Well, first is the program itself has a phased approach. In the first phase of the program, we didn't evaluate it. We knew we were in innovation territory. We knew that phase 1 was about settling down, fine-tuning the delivery mechanisms, and figuring out what we're trying to achieve. We felt it wasn't appropriate for an evaluation at that point. Whereas the SBI program, the teams worked on a defined change package. In this program, the teams themselves identify local solutions. We think, therefore, there's possibly greater traction and local buy-in as a consequence. Yes, the program provides stretch, but no one here is talking up or over-claiming about the transformative potential of the program. We know that most programs make modest and incremental contributions and differences, but few are actually transformative. So we're trying to be realistic. But critically, we're working really hard as the funder and the evaluator, which is Mary Dixon-Woods and her team at Leicester, and the technical provider, really to understand and develop a shared mental model, a shared theory of change about this. And in fact, Mary's been working hard to crystallise that in a concordat about the working relationships between the various parties and how we're going to work together, because these parties have to work together. Critically important, we said this: fine, we've awarded Mary and her team the contract. Now go away for 6 months and get under the skin of the intervention, meet the technical provider, engage with the sites, and come back to us in 6 months' time and tell us what's changed in your mind. Give us a new protocol and tell us why you think your method is or is no longer fit for purpose. And in this evaluation, the evaluation team are very much engaged with the reality of the program and provide formative feedback. But they are able to maintain their critical distance. They need to maintain their critical distance. And one final thing, I think this is fundamental, and I hope that this works really well. If it does, I think it will make a really important contribution to improvement science. Because we make this distinction between data for improvement and data for judgment, and we hold those 2 things separately, we seldom in these programs develop integrated, explicit data management plans, but we will in this program. The technical provider and the site and the evaluator will work together to have absolute clarity on the choice of measures and the principles that will guide measure selection, absolute clarity on the data collection systems and their adequacy for the job, procedures for data verification, a commitment to working together to resolve a range of known problems in quality improvement projects, a data management plan that will be signed off by the evaluation team, and the evaluation team providing absolute clarity on the kinds of independent statistical analysis that are possible. In other words, this is data for judgment and data for improvement, where all the parties are working together with a clear sense about the measures required and why, and their analysis approach. So that's a flavour of some of the learning from a Health Foundation perspective, and I'll now pass over to Gareth.
Okay, so I'm Gareth Perry. I'm a senior scientist at IHI, and at the moment I'm leading the development of our internal evaluation system at IHI. So with that in mind, I'm going to talk to you today about penicillin. Penicillin, I think this is an important and useful example to talk about. Back in 1945, a Nobel Prize for Medicine was awarded to these three people here, Alexander Fleming, Ernest Chain, and Howard Florey. Most people are familiar with Alexander Fleming and his role in penicillin, and most people kind of assume it was just him who got the Nobel Prize. But actually, these other two people got the Nobel Prize too, and it's worth thinking about, or just worth going over why they were awarded that. So, as we probably all know, 1928, Alexander Fleming, a famously messy scientist, he went off on his holidays, left behind a little Petri dish, and came back and essentially found that the mold he'd been trying for quite a few years to try and kill had actually been killed using something which had gone on in his Petri dish. He did some work on that, isolated what the active ingredients were, what was going on in his Petri dish, and called it penicillin. And then for the next 10 years or so, he tried, with actually very limited success, to produce and test the effects of penicillin, but as a surface antiseptic, so as an external, rubbing it on wounds or bacteria. And he didn't really get very far. He essentially failed. And it was only 10 years later when Ernest Chain and Howard Florey looked at some of Fleming's work. And they then were able to figure out a little bit more about what some of the active ingredients were, and produced it in much bigger quantities, sufficient to actually then test it, but not by as a surface antiseptic, by injecting it. And they injected it into 2 mice who recovered. And they continued this process. They got together with this guy, Norman Heatley, and they figured out ways to produce this in even bigger quantities. And they were able to test this in 50 mice. With that evidence, with that degree of belief having grown, they were then moved on to actually test this stuff in people. People who were coming back from the front lines of the Second World War were probably going to die from their bacterial infections, injected this penicillin into them, and they all recovered. And as a result of this growing evidence, this testing process, they were able to increase their degree of belief to such an extent they were able to then go off, do mass clinical trials to actually look at much more detail of the effectiveness of penicillin, and were able to then produce this in mass quantities, save hundreds and thousands of lives. And in 1945, all three of them were awarded the Nobel Prize for Medicine. Norman Heatley got nothing. And what's interesting, in 1998, Sir Henry Harris at the Florey Centenary Lecture, he said, well, without Fleming, there'd be no Chain. Without Chain, no Florey. Without Florey, no Heatley. And without Heatley, no penicillin. And if you think a little bit about some of the work which IHI does, we talk an awful lot about innovation, we talk a lot about testing, we talk about spread. Well, you could think about here too, and you could say, well, without Fleming, there'd be no innovation. Without Chain, no Florey, and without Chain and Florey, no testing. Without Heatley, there'd probably be no wide-scale use of penicillin. And the point here is really, when we were looking at what was going on with penicillin in the beginning, in that innovation stage, if you like, the work which Fleming was doing, we weren't doing randomized controlled trials of going away on holiday at that point. It was a very different form of evaluation, a very different form of investigation to figure out what was going on. And if you think about some of the work which we do in improvement, we often start down here in this kind of innovation phase, in the red down here, where we don't necessarily have a high degree of belief in something's going to work. But we want to look at this and do some work on this. And if we do this well, we'll find a lot of stuff doesn't actually work and it'll fail, and that's fine. Some of these things we'll actually, if we do sufficient testing, we'll move them up and put them into a pilot phase. And there'll be some, if you go to that pilot phase, will not be very good, some will reject, and some will graduate off and put into that adapt and spread phase. But in every phase, there's a different form of evaluation which is appropriate to whatever phase we're in. And that's worth thinking about when we think about evaluation. The other thing I think it's worth thinking about is this notion of degree of belief versus evidence. This is the Cochrane collaboration, their logo. I'm sure you're all familiar with them. They produce wonderful meta-analysis synthesis of various evidence, often culled from randomized controlled trials. Here's one. Here's their logo. Now, Archie Cochrane, who the Cochrane collaboration was named after, he was a physician in South Wales. He was an expert on lung disease and the causes of lung disease. So here's a picture of Archie. So Archie Cochrane clearly knew all about the evidence about what causes lung disease. Here's how Archie Cochrane acts. So it's worth thinking about how even Archie Cochrane may not necessarily always act on the evidence. So if we think about evaluation, one of the kind of big figures of evaluation, especially in the US and probably around the world, is Donald Campbell. In the 1960s, he laid out and he did an awful lot of work describing evaluation methodology, which has stood very much into the present day. But in the 1980s, this guy, Peter Rossi, he described something called the iron law of evaluation. He basically said, well, you know, the expected value of any net impact assessment of any social program is 0. This means that our best a priori estimate of a net impact assessment of a program is it will have no effect. So that's a lovely negative kind of thought here. And it suggests that most evaluations that she'd seen come back and just go, oh, there's no effect here. So we may as well just not bother. But it's actually something we should think about, and we should think a little bit about this in terms of improvement work as well. Because oftentimes, when we do this kind of innovation stuff or this prototyping stuff, we're doing so in a very small, narrow range of contexts, maybe 1 or 2 sites or 1 or 2 places. And we find that, of course, this whatever this intervention is, maybe a rapid response team or something like that, it's working. It's great. And then what can happen is that this rapid response team, whatever, could be formed into a fixed protocol, one which says use 2 nurses, maybe a doc, use this score. Once a patient goes above this score, go over to the patient. If you stick that into a fixed protocol and then try and just test it in a few more places, well, yeah, maybe it'll work in a lot of those places, but there'll be places where it doesn't work. And if you just send that out or spread that out, eventually, and you start testing it and you start applying it in different settings. So if it was initially started in academic medical centres, you're now working in district general hospitals or other types of organisations, maybe it's not going to work there. Maybe that fixed protocol needs to be changed a little bit. So there's a real danger, if we're not careful, of sending something out which is essentially innovation, turning it into a fixed protocol, and expecting it to work everywhere. That's a real danger which we need to think about. And really, I think this is the evaluation approach which really we're trying to think of in terms of in IHI, is to not ask necessarily, does this intervention work, yes or no? In other words, does it work everywhere, yes or no? But to think slightly differently and to say, well, can we actually learn, if we've got an intervention which is down at this innovation stage, can we actually learn in what context this intervention may work in? Maybe that's a different question and a better question for organisations like ourselves to try and answer. It's not an easy question to answer, but it may be a more appropriate question, especially as it focuses on learning. And that really implies a slightly different way about going about stuff. It essentially says we need to learn as we're going through from this innovation phase to the testing phase to the spread phase. We need to learn where things work, where things don't work, and we need to understand the context, and we need to understand how things can be amended to fit there as well. And there's a whole process, which the whole improvement, the science of improvement, it can actually help us with if we apply it. So really within IHI, this is our kind of central, what's guiding our thoughts on evaluation. And that's really to take some assumptions from a science of improvement perspective and say, well, it's about learning about what it takes to bring about improvement. That's really what our internal evaluation function should be about. We need to, and Dale's already mentioned this, we need to clarify to our evaluators or our external audiences if we think we're working at an innovation, pilot testing or spread. If we actually at IHI start going, oh, we're doing this spread work, but actually the intervention's only an innovation, well, the evaluation is going to be set up to do an evaluation of spread, and it's not going to work. And there's also this other issue, and the Archie Cochrane thing's kind of an interesting one. I mean, to us, improvement actually requires social change. The impact on whether people choose to smoke, that's not just a medical intervention. There's a whole pile of social factors in which people are influenced by. And the same thing happens with improvement work. There's a whole load of social factors which go into whether people are going to change and adopt these practices. And we need to bring that in to the evaluation as well and move beyond a kind of epidemiological approach here. And we need to we need to recognize that interventions need to be amended to local settings. So we can't just expect a fixed protocol just to be spread everywhere and everything to work out fine. And really to kind of take us away from fixed protocols, essentially what we need to understand is what the concepts are. What are the active ingredients? What is it that actually sits behind these interventions, which might actually form a starting point for people to test and tailor the way in terms of our local setting to actually get to improvement. This is a challenge. Concepts, that starts moving us towards theories, and we need to do some work there to actually help people develop and express the theories which they're trying to use. And with this in mind, the approach this Kirkpatrick evaluation approach is something which has appealed to us and resonates with a lot of work which IHI is doing. It has 4 levels. It asks about a participant's experience of working, say, on a collaborative with IHI. And it also asks, well, what did the participants learn? And then it moves on and says, well, there's a 3rd level which says, well, okay, so they've had a nice time, they've learnt this stuff. Did they actually change their behaviour? And we can think about it in two ways, both in terms of maybe their culture, but also in terms of their process measures. Are they now doing things differently? And then there's this 4th level, which says, did the organisation actually improve their performance? So that might be to say, did their patient outcomes improve? Did their costs change? And if we think about it, an awful lot of improvement work is actually focused on level 3 there. An awful lot of the level 4 measures there, that relies a lot of times on essentially evidence-based measures to say, well, is this clinical process the right process? Oftentimes that's where we are. And a lot of the improvement work focuses more on the levels 1, 2, and 3. And with that in mind, whoops, I'm going the wrong way. What we're really thinking here, as we just kind of change this diagram around, is to say, well, at the start of any IHI program or project we're doing now, we're going to try and get clear on what our conceptual model is. What's the theory here? And we're going to break this down into 2 pieces. It's the bit which says, well, what's your content theory, which says, what are these process measures? What are these clinical processes? What's the evidence which sits behind them? And if we think we can get those done highly reliably, what are the changes which we would like to see in patient outcomes? That's one piece. But then there's this other piece, which is what we're currently calling this kind of execution theory, which says, well, what is it that we as an organisation are going to try and do here? And if you think about Kirkpatrick, we're thinking, well, what's the experience we're trying to give people? What is it that we're actually trying to teach them, and how are we actually trying to teach them this? So that actually then what is it, the theory which, once they've changed that behaviour, will lead to change in their process measures? This is almost getting at a sort of program theory approach as well, at the moment we're calling this our execution theory. And we're going to ask people at the start of any project, we can say, well, if you have an aspirational goal, well, what is it? Fine, that's nice, but what would actually be considered success? So it's fine to have an aspirational goal, but recognise it as a motivational-ish thing, a goal or something. Let's think about what we can actually achieve in the timescale of this project. Let's think about what data we can collect, and let's look at some of this other stuff. Let's make sure we can ask people about what's enabling or becoming a barrier for improvement, asking people what worked over time for them. And with that in mind, what we'll then do is we'll collect all this data, and we should end up with a new conceptual model at the end. We should update our execution theory, we should update our content theory. I mean, if we do this well, we may even be able to do this as we work our way through this project. So that's the overall approach which IHI is now taking. And I think it's you know, from a lot of our learning from the work which we've done in SBI, as Dale was talking about, a lot of this model has been informed by that. And I'm going to now move on to Mary to take us forward.
Thank you very much. So what we thought would be very helpful is if we summarised our learning across the 3 roles that Dale described into some lessons that we could share with you. And we've identified 7 principles that we think should guide evaluation and that will help us get evaluation right. So that's what I'm going to take you through. And the first and most important principle of all is that at the beginning of any intervention or programme, you have to commit that the care of patients is going to be your first concern, that the only reason we're doing any of this work is to make things better for patients, and that you have to commit as part of that to learning. This brilliant paper published last year by Ruth Faden and colleagues talks about how we have to commit as health systems to learning, and that's an underlying ethical commitment. The second thing you need to do is have a good programme theory, and Dale and Gareth have already both emphasised the importance of this. I love this paper by Mark Lipsey from 1993, The Small Theories of Treatments, in which he says that nothing improves research design so much as having a clear idea about what is being investigated. An important function of theory and research design is to help researchers ensure they're playing in the right ballpark to begin with, to help them avoid studying the wrong thing. And I think we've had some really interesting examples of how we can learn to study the right thing. Well, there are lots and lots of challenges in building programme theory. We have to think about the values and interests that are embedded in that programme theory. Sometimes what you will find is that there are interests at play. People are often very committed to showing that what they are doing is effective, and we have to put those aside. We have to surface them and say the only reason we're doing this is to make things better for patients. What's relevant to that then is whose definition of success gets to count. Gareth has already said we need to know what success looks like. From doing lots of these evaluations, I know that success looks like different things to different people, and whose definition of success gets to count in the end is really important. Again, I think if we go back to patients, it's whether it worked for them that we need to think about. What are the responsibilities of evaluators? One of my less enjoyable roles as an evaluator involves holding a pin and bursting people's bubbles. And a lot of what we're trying to do is look at things critically, but in a constructive kind of way. What we would often like to do is get in early, surface the programme theory, work out what the different parties involved are trying to do, why they're trying to do it. Very often we can spot weaknesses in the causal chains, the kind of mechanisms that people think are going to work. We can also look at the extent to which the goals that the programme has set itself look viable, and so on. But we also have to maintain the kind of critical distance, because what we can end up doing if we're not really careful is that we start becoming part of the intervention. So we begin co-designing the intervention and altering it. And so that's not an easy thing to manage. There's also the question of what's deemed to be evaluable and what's seen as the things you can legitimately look at as an evaluator, and what the different parties involved in this relationship think are the goals and the evaluable elements. So very often, as an evaluator, you're asked to look at the goals of the programme. Did the programme reach its goals? We might often say you need to look at the side effects too. You're not just interested in did it hit these targets, but also did it produce iatrogenesis. Often we're interested, as we've heard, in how does a programme work, not just does it work. We're interested in issues about credibility and who this is going to be credible to. Again, one of the things you find frequently as an evaluator is that locally collected data does not have the same quality as data that's collected independently, and you then have challenges when you try to sell this back to the next site because they just don't believe the data. When you're doing evaluations, it's often very threatening for lots of people. And I think a question you need to start asking right at the very beginning is who really wants to know the answer? When people ask for feedback, the only thing they really want to hear is you're doing really great. And when you come along and say that this really isn't all that, or this really doesn't work, or there are parties who are not performing, this is very threatening. And there are lots of people who end up being threatened by evaluation work. We also know that there are going to be lots of difficulties in accessing data on some measures, and sometimes the things that are really important to measure and the things that are really valuable to know about are the bits that are the hardest to access. And I don't mean just quantitative data, but all kinds of other data that we really need to get our hands on if we're going to produce a holistic assessment, but it's actually very difficult to get hold of that. We know evaluation as well is costly, and I don't just mean the direct cost to whoever is funding the evaluation. It's costly to the people in organisations who have to cough up the data, and we have to be sure that we don't impose burdens on organisations that distract them from clinical activities in order to produce data. Lots and lots of ethical issues in doing evaluations, which we don't have time to discuss in detail today, but may be worth coming back to in the discussion. I think we have not sorted this issue out at all. We've stuck with this service improvement versus research divide, which I think is not helping anybody. And we need to think about a new set of responsibilities and ethics. And I mean ethics in a very, very ethical way. Who are the people we're trying to serve by doing this? What responsibilities do organisations and individuals have to allow themselves to be studied so others can learn? The issue of dosage has already come up. Now, if you're designing a drug, you know that there is a very clear distinction between the design of your molecule and the dose. And you often have got the molecule right, but you don't know what the dose is going to be. So you spend a lot of time in pharmacogenetic studies trying to figure out how do we optimize this molecule? How do we know when it's going to provoke a response? How does it get metabolized? Does it produce toxicities elsewhere in the system? We need a lot more clarity about dose response in improvement interventions. We need to figure out when we have a really promising idea and we think this really is the right way to go, but how do we optimize it? How do we optimize the model? How do we know when we've done enough of that and when we have tripped over into actually creating a toxic intervention because you're doing so much of it, you're displacing attention, activity, and energy from other activities of the organization. You need to know what mode you're in, and again, this has already come up. An awful lot of the time, what we're seeing in quality improvement interventions is that people are in prototype mode, they're innovating, but we also know that an awful lot of the time people aren't really innovating, they're doing something that's been done many, many different times before. The principles that they're using are very similar, but we don't have cumulative learning going on as much as we should in quality improvement. Very often the kind of evaluations that are done of prototypes are not fit for purpose because we're pretending these are fully worked up interventions, that we're clear about mechanisms and we're looking for effectiveness. So we're putting the wrong kind of evaluation designs into looking at prototypes. If you were going to evaluate a drug, you take it through a whole stage of clinical trials designed to do different things at different stages before you ever got near full-scale testing and putting it into real live patients. I think we need to come up with a similar way of thinking about improvement interventions. So knowing how you fit the design to the mode you're in is really, really important. And I think distinguishing between the design of the intervention and the implementation is very hard to do. But we need to make, and I know this is a heuristic distinction to some extent, but we need to know more about implementation versus design. Choosing the measures wisely cannot be more strongly emphasised. Too often we see measures that are not well chosen. What you need to do is start by figuring out what it is that this programme is trying to do and how, and then choose your measures. What we see too often is that the measure is chosen without reference to the programme theory, so it's too hard to figure out what are the causal chains that link the thing that you're doing to the measure that's been chosen. You also need to think about whose interests are going to be served by those measures and their effects. And measures because no measure is free of the interests embedded in it. We need to think about who benefits from measuring it in this way. We also know from a very, very large body of social science research that, and indeed scientific research, Heisenberg tells us you can't know where an electron is and know how fast it's moving at the same time. So as soon as you start measuring, you start affecting what you're measuring. So being sensitive to the impacts that your measurements are going to have. We know that if you don't choose your measures wisely, you end up not being sure about whether your program worked or indeed whether it failed. We know that if you don't choose your measures wisely, you risk goal displacement, where people start pursuing the thing that you're measuring and neglecting the things that may be much more important or equally important but aren't being measured. And we know that there are risks of gaming, and this has been very widely studied, and we know it happens. We often don't study exactly what's going on in gaming. One of the recent studies that we have done for the Health Foundation suggests that it's not always gaming that's going on, it's simple incompetence and not being trained in how to collect data, or different interpretations of what appear to be standard definitions across sites. Measuring has lots of unwanted consequences. We create incentives to respond to the measures rather than the intentions behind them, and every single person in this audience can tell us about how people became driven by ticking the box rather than doing the thing that you introduced the box for, creating tunnel vision, sub-optimization, myopia, measure fixation, and failing to capture subtle but very, very important changes that may be important to patients. We have to defend against the conspiracy of enthusiasm that bedevils quality improvement. We have an awful lot of very enthusiastic, well-motivated, committed people, and we have to harness that energy, that enthusiasm, that goodwill, and make it add more value. We have to get away from the problem that I've called him Donald here, not that we're on first name terms, that Campbell identified more than 40 years ago, that we have to get away from reforms being advocated as if they're certain to be successful, and we have to be able to advocate without the excess of commitment that blinds us to reality testing. The unwillingness to admit failure. We have a massive publication bias problem in quality improvement. Basically, unsuccessful quality improvement projects are not published. And that violates the ethical commitment to learning. It frustrates progress because people who come up with the same bright idea don't realise it hasn't worked, or they're not focused on how you optimise the model. And pressing ahead with interventions that aren't going to work eventually discredits the whole enterprise and sours people against improvement work. The last point is to re-emphasise the need for independent evaluation. It's not always possible, and there may be new models we need to develop for how to do this. But it's really important that where it's possible to do it, it's done, because it provides the legitimacy and the credibility that improvement work needs. It commits to the scientific enterprise that needs to lie behind this. We know that very often the results of programmes are more modest than are hoped for. Sometimes it's a null result or negative. We also know if you leave people to collect the data themselves, they're much more likely to come up with a positive result. And exactly the same thing happens in drug trials. If you leave drug companies to study drugs, they come up with much more positive results than independently commissioned studies of the same drugs. When you come back with a not very welcome finding, you can expect that this is going to be very, very uncomfortable for various stakeholders. It can be very threatening, it disturbs relationships, and you need to plan for it in advance, which is something we have learned. Evaluators are often in lots and lots of different principal-agent relationships, by which I mean it's not always clear who the client is and who you owe your allegiances and responsibilities to, and partly that's because we haven't clarified some of the ethical issues about doing this kind of work. But I want to conclude by suggesting that there are ways forward. If we're going to do evaluation, we need to have explicit agreements from the start on all sides that clarify what we're trying to do, why we're trying to do it, who we're trying to do it for. You need to plan well in advance for communication and dissemination, and plan for the uncomfortable situations. Avoid getting into relationships that are too cosy with any of the parties. It should be an amicable but not necessarily cosy relationship. And you have to get everybody involved to sign up to the values. The only reason we're doing this improvement work is to make things better for patients. And I think if we keep that as our North Star, we can go a very long way. Thanks very much.
The only reason I'm coming up here is I'm hidden behind the screen, but this is now the time for some discussion, and I hope you'll ask some tough and provocative questions because these excellent speakers made it seem like so easy. I'll start with a question, and then I think there are microphones here. If people could line up at those microphones, and I've been known to call on people because I recognize some of you, so please do line up. This question that any of you could answer, you know, some of the work we do to demonstrate improvement is relatively small scale. And in those situations, the entities involved may well not have the expertise necessary to do the mixed methods qualitative, especially inquiry that you were all talking about. In very large demonstration projects, the expertise may be present, but even on a large budget, the expense and time it takes to do this kind of evaluation may be seen as prohibitive. So how do you deal with those kinds of issues that seem to crop up from time to time?
Happy to have a go. Well, I think the first question is utility. What's the purpose of the evaluation? So when you're looking at small-scale improvement projects, I think it's really important that those evaluations are owned and led by local projects, and particularly that you're asking the question at local level, what is going to be persuasive at a local level for you to build a business case for quality? Because sometimes big evaluation teams coming in on multiple projects haven't got a good sense of that. So actually, I think often for projects, you want locally owned data and a real sense of what the purpose is at a local level. For larger projects where your contribution, where your intention is about adding to the evidence base, and of course in those circumstances you need more rigorous scientific evaluations. So I think it's about purpose fundamentally.
Okay, well, given the number of questions that are out there, maybe we'll leave it at that and we can continue to think about that dilemma. Sorry, I can't see you, but I think it's a woman in a reddish...
Thank you. Your presentations were excellent. You talked about publication bias, and I just have a question. I don't know if you've come across this. It's interesting because in doing the background work to support quality improvement before you actually get to the study, when you go to try and publish this information, what happens is you go to the quality journals and they say, this is very interesting, but it's a clinically focused thing, and we think it would be better for a clinical journal. And when you go to the clinical journals, they're not really well equipped to deal with quality improvement projects. So I didn't know if any of you had any suggestions related to that, or whether in your roles as quality improvement experts, you might be advising journals on how to deal with those types of projects.
So that's a very, very good question, and I'm part of the problem here. So I'm Associate Editor of BMJ Quality and Safety, and our problem is that we are trying to establish research in improvement as a scientifically legitimate enterprise, and we get an awful lot of quality improvement reports that do not meet standards of scientific excellence. We have a limited amount of room in the journal, and we end up rejecting an awful lot of those reports. So I'm part of the problem that there is a major publication bias issue. I think we need to change the infrastructure, and we need somewhere where those quality improvement reports can be published. We need to think about how we can fund that. It could be a pay-to-play model where people are prepared to pay a small sum in order to publish their quality improvement report, and we might need to think about some kind of buddying peer review process, but I really think it needs to happen. I'm not sure how it's going to happen, but I'm really glad you started the conversation.
Okay, let's come over here.
Yeah, mine partly follows on from the previous discussion. You made a very good case about why you needed to be independent evaluators, although rather uncomfortable feeling us being compared to drug companies. But my concern with that is that we traditionally go out to a university and we contract independent evaluators, and we don't spend any time developing that skill in-house. So we are not building the capability for the small-scale innovation evaluation. So we either have nothing or a great big expensive external one with all the pros and cons that that has. So I just wanted to bring us back to actually building the capability within organisations as well as having independent.
I mean, actually, from an IHI perspective, the internal evaluation system which we're trying to build, I think if we can do it successfully within IHI, we might actually see that as a potential for helping people. I mean, the evaluation system we're trying to build is essentially a learning system, rather than a kind of did this work, yes or no system. I think that model might offer an approach which would, it's essentially a system which is an extension of a whole model for improvement if we do it well. So that, at least from our perspective, might be
Especially
one approach to
if you're interested in why it worked or why it didn't work, rather than the binary yes/no.
Yeah.
You need people that are involved to do that.
Yeah.
I think you asked a really good question. Certainly at the Health Foundation, increasingly we're thinking to try and build local capacity and capability in our improvement teams, provide on-tap support for evaluators to work with those teams and develop their theories of change, identify their data management systems. I think that's a good point.
Hi, I'm sorry I'm jumping the queue here to some extent, but I'm actually the editor-in-chief of the International Journal for Quality in Healthcare. My name is Eric Schneider from Boston, and we're actually also an evaluator of an IHI intervention that's in the field right now. I just wanted to make two comments. One, to echo Mary Dixon-Woods' point about the challenges as an editor in publishing this type of work. And I don't want to point the blame to peer review, but peer review is often the barrier that we're dealing with. And so coming up with a more effective peer review system of people who can contribute as peer reviewers to this type of work, I think would be another component of what you were suggesting. The second question was around, I think it's a very helpful clarification to differentiate pilot testing, innovation, piloting, and spread. I think evaluation, we almost should reserve the term for the spread. The pilot and the innovation cycle testing, I think also deserve independent testing or an independent body. And so I think while it's helpful to develop in-house capability in that regard, the credibility of those innovation tests and pilot tests and sort of small-scale demonstrations also will depend on the independence of the people doing the testing to some extent. And I don't know where along the continuum it's really most valuable to have the independent perspective. And then a question was around funders and the degree to which funders get involved in this. Many foundations are interested in creating actions in the world now. They're not. It's not sufficient to sort of to be the funder of evaluation. They also want to fund the changes that would go along with that. And so to what extent are funders conflicted in sort of playing these two roles? I'd be curious to hear the panel's thoughts on that.
Yeah, interesting question. So at the Health Foundation, we fund major programs of improvement and at the same time fund independent evaluation. We've always made a commitment to publish all of that research, even where the findings are uncomfortable for us. We think those studies, whether they provide positive results or null results, make important contributions to the science, and we'll continue to do that.
Let's swing back over here.
Thank you. I'm Cathy Howe from the Clark for North West London. Thank you for your presentations. As ever, articulate, fascinating, interesting stuff, thought-provoking. I get a sense that there's some form of conflict, and I think this builds on the previous comment, between evaluation reflexivity and being aware that evaluating can have an impact in the process versus the potential for maximising the improvement of improvement, and when feedback from evaluators in relatively real time perhaps could continually to iterate a programme approach as opposed to an individual project approach. And that strikes me as a bit of a tension in terms of credibility, independence and the time required to demonstrate what impact is being had. And I wondered if the panel had any thoughts on that.
Yeah, so we've done it both ways. We've stayed completely apart from programmes as they roll out and waited till the end and then come back and said, this and this was good, but if you'd only just changed this thing in month 3, this would have been so much better. And that's quite a frustrating experience for everybody. So what we're now moving to is having formative feedback. That there is no perfect way of doing this, because we do end up becoming implicated in the intervention, and we end up helping the teams and the technical provider, whoever it's going to be, refine the intervention in real time. So we tried to do that through negotiating this contract up front, and we tried to provide the feedback in formal ways, so it's documented what we said and what actions happened, and we're very clear that the parties involved can completely ignore us and don't have to do anything. We don't take responsibility for programme delivery. So it's not perfect, but it's probably the best we can do at the moment.
Yeah,
good question.
And I was going to go back to this kind of conflict between the sort of the internal evaluation, external and therefore independent evaluation. I mean, I'm not necessarily going to offer an answer, but I'm merely an observation. But I guess, in the biomedical world, again, if you think even about Fleming back there, he would have published the results of his study looking at what was going on in his Petri dish. As it's his work, he published it, he didn't get an external evaluator to come in and look at it. But I think the idea there is that he will that in the biomedical world, you publish what it is you're found in a way that allows other people to try and replicate it. And the kind of evaluation process is almost through that replication piece, to a degree. I mean, I think there's some model around something like that which might be worth thinking about here.
Kathy, I think it's a great question, and in my discussions with evaluators, this is the one thing on which we butt heads more than anything else, because I think it's a question of science versus pragmatism. Quality improvement is a data-led approach. It seems to me disingenuous and wrong, on the one hand, to have data for improvement running through the life of a program and all this evaluation data in the background not feeding into it. I struggle with that. I appreciate colleagues, particularly those doing before and after studies, will want to protect and not have their studies contaminated, but I think there's a balance to be struck. So I think there's a useful distinction between feedback and advice, actually. I think making feedback to organisations is a good thing for evaluation to do. It adds value throughout the process, but don't give guidance.
I'm Dan Cohen. I'm International Medical Director for one of the vendors here, Datix, but I also do independent international healthcare consulting on technology assessments. And what amazes me, I really appreciate your presentation today, I think the evaluative process for research should begin during the planning phase for research. The universe has given us chi-square and regression analysis for a reason. And there are many people who have innovative ideas, but they don't involve the people who understand statistics early in the process. And as I look at studies from international companies who are wondering why they can't get insurance companies to pay for their technology, and they send me reams of studies that are absolutely worthless. It's just incredible, the lack of understanding of scientific methods in a community which really should be at the forefront of leading the change. I think it contributes to inertia. So my comment is that innovation and evaluation go hand in hand, and Alexander Fleming needed to have an evaluator standing by his side.
He probably wouldn't have won the Nobel Prize then.
I didn't mean for everybody over there to evaporate. I guess I wasn't clear.
Hi there, I'm Pat O'Connor from NHS Tayside, one of the first SPI sites, and thank you very much to all the speakers for their different perspectives. I think I've certainly learned something from all of them. I would absolutely agree with Dale that the results were modest at best and were very difficult to evaluate. I'd also like to point two things out to the entire audience, that Alexander Fleming and Archie Cochrane were Scots. So there's something about Scotland if you looked at the plenary. And it's on that note, Dale used a word like transformation. Gareth used a model that I think we could look back, which is what we do with penicillin with every single RCT trial that comes. And I think we should look at what does the UK look like with the SPI 8 years on, and where are these stars, what's happened to them in relation to Gareth's model. So thanks very much. I think we could then use Mary's rigour of the components that she set out to do that.
Just another quick thing, actually. So Howard Florey's son, Charles, was Professor of Epidemiology and Public Health at Dundee University. So
there you go then. There's something about Scotland.
Okay, so you get the last word, sir.
Thank you. Saadi Tahir from Saudi Arabia. My question is really proximal to what has been presented. And it relates to the science of improvement, the relation of that to the science of change and change management, the learning healthcare system that has been mentioned a couple of times, and that relates to the work of the Institute of Medicine and Donny Cortez value and science-driven healthcare, and the 11 reports that they have generated in that area. They emphasize the system theory, system design, the interface between systems and medicine and engineering. And there is, at least in my mind, there is a huge need for a platform that brings all these sciences, in addition to what we heard yesterday, the social sciences, the anthropology, the ethnography. Now, how does, with all the intellectual power sitting here on the podium or down in the hall, how does one go about creating such platform in order for all these sciences to converge towards pushing the healthcare system forward in the way that you have been trying to do? Thank you.
Well, I think we're beginning to see these multidisciplinary teams who can do evaluation work coming together. I think they work best when they're partnerships with the organisations, the clinicians, the practitioners, the managers. All of those people come together and commit to learning. And we're beginning to see evaluation models beginning to appear that are much better fitted to quality improvement. It's been done for clinical science. 25 years ago, you had people working in disciplinary silos, and it's become clear you get most value when you put lots of disciplines together and you push the science on. Thanks very much for your question.
Okay, well, thank you all for joining us today. Thanks to the panelists.